question.
So it's the question and answer session now. So any questions from the audience? Yeah.
I just wondered with regard to the LFDs, from everything that you said, the accuracy is really very high. And we do, I mean, I work in infection, I head up the infection directorate in dichotomies, so I'm completely familiar with the whole process over the last 4 years now.
Yep.
And we are still PCRing almost every patient. Now, for me, there's an efficiency there.
Absolutely.
And I want to be able to use it, and I just wonder what's the next step? How can we get to that? Because what you're saying, and this is what my consultants tell me, that it's almost as reliable. And obviously there'll be individual cases where we will need to follow up, but not all of them.
Yeah.
What's your thoughts?
Well, this is the conversations we've been having with Dr. Batra around kind of moving away more from PCR testing. And absolutely, as we said, there will be the case for it. But I think as we continue, there's a report that's due to come out from UK HSA which looks at the CT value of the lateral flow test, and the work that SureScreen have done continues to improve that. From our perspective as a digital reader, we can only read the test that we have, and I think there was one of these ones here. So these are some of the examples that we're picking up here, the positive results that are missed by users. And we read all the way across the gel lane to be able to kind of remove artifacts and look at the kind of, but ultimately as a digital reader, we're driven by the sensitivity and specificity of the test. And whilst that continues to improve, that then negates the need for PCR testing, because as you saw from there, £32 for a PCR test versus pounds for a lateral flow test is huge.
When we were using blood filters and before it's linked to the ethics system, it was not really viable to suggest this.
Yeah.
I think it needs to move forward at pace now.
Yeah, well, I'm more than happy to pick up the conversation with yourself and Rahul. Thank you.
Can you do a full blood count with it? Can you take a pinprick of blood and look for hemoglobin, white cell count?
Yeah, so there are a wealth of lateral flow tests you could do, and I think I alluded to in one slide. The ones that we're looking at are the nasal swabs, but our pregnancy tests are urine. We have CRP tests that would be blood, or be D-dimer tests. So one of the things that Mark had been looking at, and once we developed the Strep A test, was there was a region of the UK that was looking at putting Strep A tests and CRP tests into every pharmacy. So if there was a Strep A crisis, the parent could take the child to the pharmacy, have a Strep A test. If that came back positive, doesn't necessarily mean referral, but then they could do a CRP test.
How do you get a percentage? How do you get your CRP number?
The CRP is actually, at this stage, would be low, medium, high.
Okay.
So the lines that I showed, you could adjust the sensitivity of the line, so that if all 3 lines were ticked off,
right,
we're calling that high CRP. The ambition would be just have one line and read it and look at the density of it, and the density would tell you.
Yeah.
And you just need to do thousands of samples to create the program that could then say with confidence that density equals that.
That'd be amazing.
Yeah.
I mean, everyone's measuring the infection in hospitals on 3 very simple parameters. White cell, CRP, SR. If you could do all that on one.
And just to give you another use case, so we've just started a trial with Mid-South Essex for PSA screening. So that's a capillary blood test. So, and again, the benefits of that test is it's a professional use test. It's done at home. The result goes back to the clinician to interpret the result. But the health economic benefits mean that that person doesn't need to travel in for a venous sample into the hospital. They can still do that test at home. So from a screening perspective, the clinical utility is huge, because yes, you will pick up more false positives, but ultimately you're hopefully picking up more people that have cancer. So.
Yeah, great technology. Any other questions? Yeah, far away.
Just a quick one about that, because I was quite interested in the urine testing as well then.
Yeah.
From a digital point of view, looking at the elderly, I suppose, from a care perspective in terms of being at home. This clearly you're talking about large hospitals and large trusts. Is this something that could be scaled down to a private organisation that could utilise this technology to look at things like, are they drinking enough? That basic level is quite significant, isn't it, in the elderly? Is it something that could be procured at a much smaller scale?
100%, yeah. So when we work with companies, we have a software development kit where our digital reader technology can go into existing apps that already have a community within a certain space, but that leverage our technology to read tests.
It's whether I'm understanding right. We pre-COVID had urinalysis strips, and the app is being programmed at the moment for a tender that would read the urinalysis strip and interpret the results. You know, you get 12 different parameters. So that sort of stuff, and we're talking to private hospital providers about whether HbA1c tests could be carried out. It would be, at the moment, not fully quantitative. It would be low, medium, high, semi-quantitative. But that result could be with the private doctor when the remote or face-to-face consultation
I mean,
happens.
Even a family member, you know, in terms of a member of their family that's just not making enough.
Yeah.
Low, medium, high is enough, isn't it?
Yeah.
To prompt
Yeah.
a daughter or a son to go around.
Yeah, using it for measuring, you know, anticoagulation, INR and so on would be great. I mean, it could be incorporated a lot into the technology you've got, Martin, with your Halo package. Yeah.
I think the holy grail of this sort of stuff, listening to our scientists, we've got a project ongoing at the moment that will be some distance away, would be a sepsis test that would not diagnose, but if you had the right combination of markers, because the early intervention with sepsis, you're talking hours are important, not days.
Or pick up specific cancers that have got antigens that, you know, very well defined markers for specific cancers. I mean, it's coming, isn't it? Where we can all walk into the pharmacy and work stuff out a bit more quickly. Any other questions?
I just wanted to ask a question about the this gentleman here. Sorry, name escapes me.
Sorry, Mark.
About the digital care. I'm very curious about early stage dementia patients and whether you actually had any early stage dementia or have indeed got any early stage dementia. Because I think, I mean, and thank you, because I think I absolutely agree. This is the answer, to have that, you know, that human contact as well, but minimally so. But I think we are perhaps 10 years away from those early stage dementia patients being able to use the technology. Because whilst I know there's clear evidence that the elderly don't necessarily use technology any less well than we do, I think dementia is a different case, and I think they do struggle with digital technology. In my anecdotal experience as a carer, are there early stage patients living alone who use it?
Yeah, they do, yeah. Again, you're probably right. I mean, if you look at a trend across it, there would be certain times when there is more of an impact in not using it, if you know what I'm saying to you. If they're going through a certain stage of it, whatever it might be, there could be a slight change. But because of the phone calls that are being made to and the encouragement and the conversations, a lot of that is captured and they do use it. We've had very little, well, the chief clinical officer now, in fairness.
So where our system is supporting people with early dementia is, just to give an example, is where we have a client with early dementia that starts to deteriorate. But because the family have that app, they're able to see that dad is up all night and he's agitated. They wouldn't have known that otherwise. He became dehydrated because they noticed that his bathroom use was reducing. So by that then they were able to pick up, well, dad is deteriorating, there's a change in him. And it came down to him being dehydrated. And that was through access to the data and the information that's on the app. Fiddling at the front door, trying to wander, trying to get out, all of those symptoms are picked up through our system. And then because we're talking to these clients every day and ringing them, and if we have any concerns, we notice a change in the routine, we can notify the family of the circle of care and allowing them then to get the care that they may need. Now that gentleman was on hospital prevention admission because they picked up on dehydration very quickly and rehydrated him and didn't need to go to hospital as a result. We have early dementia patients who love games like Max Solitaire and those sort of things on the tablet as well. And the other element is that they love photo share. So we've a lot of children and grandchildren that live abroad
You could really scale it, Martin, to Apple Home, couldn't you? Everyone's got their, everyone gets futuristic and they open their front doors as they're approaching and they turn their lights on and, you know, Alexa's doing this and all the rest of it. You could see an app like this where you could very easily integrate into an Apple Home system where you're also picking up on a lot of these.
Yeah,
And
but
even
does-
for dementia patients who forget to eat and drink,
Yeah.
we can detect that through the technology because we know they're not using the devices and notify family.
And
Forget to turn on the heating, all of those things are
is
so
it ready for the
important.
UK?
Oh, absolutely, yeah.
So
That's
what you-
fully cloud-based, yeah.
And
I'll be
you-
here in the morning, there's not a problem, you know.
And you'd monitor it from Ireland, so
Huh?
you'd be monitored
Yeah,
the
from the
patients
care
in
hub,
Ireland,
yeah. That's not an issue.
Oh,
We're doing a bit of
yeah.
work in the States now as well, so I mean, it doesn't seem to be a challenge, to be perfectly honest with you, you know, under some of the pace
I mean,
providers.
my own mum's 80, she's pretty fit, but 3 years ago she was, heard a noise, went outside, slipped over, had 3 rib fractures. She had a sort of a hip fracture, great trochanter fracture. It wasn't like a terrible hit, but she managed to sort of crawl to bed, and she was outside for hours. It's just the sort of thing all of our relatives, family members, parents need this kind of technology, definitely.
Yeah.
Yeah.
Any other questions? Okay, we'll wrap it up there. Thank you, everyone,
Thanks.
and great presentations. Thank you.
Thank you. Thanks very much.